Wonderful. Apologies, I'm at the tail end of a cold, so if my voice starts to taper off a little bit, apologies for that. Okay, I will jump right in. I'm sort of talking about two different things, both comorbidities with mental health and physical health conditions, as well as using longitudinal secondary data to address these comorbidities. I have an ambitious outline for a 10-minute talk. So this is much more about breadth than it is about depth, but I am happy to answer any questions afterwards or have a chat about any of these afterwards. Okay, I'd like to start by talking about the challenge of mental health and chronic physical health conditions, comorbidities. Epidemiological evidence suggests that both mental health factors and chronic physical health conditions are essentially risk factors for one another. And there's a good amount of epidemiological evidence to suggest this. And I put some examples on the slides up here. I'm not going to read them all, but just to give you some ideas, just to quantify the scope of the issue. Some examples would be that there's a 44% higher risk of cardiovascular mortality for those with high trait anxiety versus those with low trait anxiety. We see similar findings with depression as well. And this is a bidirectional relationship where these are risk factors for one another. For example, the prevalence of depression amongst heart failure patients or similarly people with other cardiovascular conditions is much, much higher than what we would expect at the population level. For example, here this meta-analysis found about a pooled prevalence of about 28%. A lot of the examples that I have on the slides here come from meta-analyses. We see these associations with cardiovascular problems. We see this with diabetes. We see these bidirectional relationships. We see this with cancer. We see this with chronic respiratory illnesses. And we also see a burden of multimorbidity. And so having several chronic conditions seems to also be associated with an increased psychological burden. So we see evidence across a number of health conditions, mental health and physical health conditions, and many of these, not all, but many of these do have bidirectional relationships. And what's interesting is that often these relationships are over and above traditional risk factors like lifestyle factors. So a lot of the work that we do in my lab is to try to better understand this comorbidity between mental health and physical health conditions. So we're really interested in understanding these kind of biopsychosocial, behavioral, environmental mechanisms that are driving comorbidity. And I put a few examples on the slides right here. And we use a number of methodologies to address these. But one of the ones that we do use often is the use of secondary data from prospective cohort studies to better understand directionality of these associations. And I'll give an example of our current HRB-funded project, which was generously funded by the HRB, thank you very much, from the Secondary Data Analysis Project Scheme. And for this, we're trying to investigate in much more detail the association between depression and diabetes, looking at this in both directions, depression as a risk factor for the onset of type 2 diabetes and diabetes type 1 or type 2 as a risk factor for the onset of depression. And what we're interested in doing here specifically is comparing what this looks like, what this comorbidity looks like across a number of different countries in Europe. And we were inspired for the study by a previous cross-sectional study that found that the association cross-sectionally between depression and diabetes was stronger or varied across countries in Europe. And interestingly, was actually the highest out of the, I think, 19 or so countries that they looked at, was actually highest in Ireland. So we were interested in following this up with longitudinal data so we could better understand what those risks really mean, what is the direction of that effect, and how long does this go on for. So for this, we have an international team. This was really important because our team has a lot of experience in these different data sets that we're using, and a multidisciplinary team. Sorry, there goes my voice. So we have expertise in psychology, population-based medicine, sociology, health economics, health sciences, and what's really important as well is that we have our Diabetes Ireland, which is a charity in Ireland. We have Tilda on board as well, which is one of the data sets that we're using. And importantly, we also have lived experience expertise on our team of co-investigators. And we're using data for this study from Ireland, from England, and from the SHARE data set, which is a number of countries in Europe. So this is ongoing. I'm happy to chat about this if anybody has any questions about this project. But I wanted to move on now to why we study comorbidity. And ultimately, this does help us to inform population health and promote well-being in the population. And for this, I'd like to draw inspiration from this WHO report on comorbidities and addressing comorbidity between mental disorders and non-communicable diseases. So in this report, which was inspired by global data, they found that comorbidity is a major public health challenge globally. And independently, mental disorders, this is not going to be news to anybody in this room, but independently, mental health conditions and chronic health conditions are worldwide are a major cause of disability and death globally. But the reality is that these are not independent. They often co-occur, and when they do co-occur, outcomes are often a lot poorer. So outcomes like quality of life, disability, and mortality. And that these are really not independent either. They affect one another. So for example, mental health conditions can be a precursor or can be a consequence for a number of different chronic health conditions. But despite this, comorbidity is often routinely overlooked. But if we could address these challenges together, ultimately we could potentially improve population health and help reduce the burden of disease. In order to do this, we need good data to better understand the scope of the issue. So long-term, longitudinal, multifactorial data with a number of different sources of information from psychological factors, environmental factors, biological factors, the list goes on, is really essential for us to better understand what is driving this comorbidity and what the long-term effects are. And ultimately, we need the data here to be able to guide policy, guide integrated care guidelines, and advance personalized medicine. So by having access to things like the prospective cohort studies and other secondary data sets that are, especially that are longitudinal, can help us to make a lot more efficient use of limited time and limited resources. So having something like the Secondary Data Analysis Projects Call from the HRB is fantastic. It's a great initiative to be able to kind of harness these secondary data sets and try to make a difference. So longitudinal research obviously takes time and a lot of resources, and a lot of funding initiatives don't allow that length of time to actually occur to be able to follow, to have that longitudinal data, at least long-term longitudinal data. So secondary data sets that are prospective cohort studies can really help us to better understand this. And of course, the longitudinal data can help provide slightly better insights than something like cross-sectional data. It gives us an indication of directionality. It allows us to study these outcomes in the long term. So this is really essential, and of course, it also there's potential for opportunities with data linkages and other health resources to try to get a really comprehensive picture. I also wanted to talk a little bit about the potential for recontact projects from large data sets. Large data sets, let's say from a community survey, even if it's cross-sectional, we could do something like, or some cohort studies, some data sets offer the opportunity to recontact participants. We've done a few of these projects, and they're really, really informative because you can create essentially a longitudinal data set in one shot, in one form of data collection. So this would be, for example, recontacting participants who provided maybe biological data, maybe some survey data in a community cohort study 5 years ago, And you might, from a large study, you might identify subgroups that you're particularly interested in and be able to, obviously if they consent and if the data infrastructure allows you to recontact them. And maybe you could do personalized, more detailed interviews. Like we've done these and have done follow-up diagnostic interviews and other. So you could do other, sorry, it's flashing at me and it's telling me to stop talking. So you have a lot of opportunities with these data sets. Some offer them, but it would be great if there was a few more recontact opportunities so then we could create more longitudinal data sets this way. Obviously, having these large data sets also helps us that we can identify subgroups that are high risk for comorbidities. And you need these large data sets that have a number of variables that can offer potential for controlling for confounding factors with identifying subgroups and with enough statistical power. So this is an advantage obviously in overburdened healthcare systems. Some strategies might not be effective for, say, for example, for preventive care at the population level, but potentially if we're really aware and have data-informed subgroups that have higher risk, then this could be a better use of those resources. And finally, this can also be helpful for identifying health disparities, especially if we merge and combine a number of different data sources. And ultimately, this can help with prevention efforts and improving population health. Okay, thank you.